Welcome, everyone. Thank you for joining us for today's webinar, Overcoming Barriers to Care for High-Risk Women, how you can use low-cost digital tools to improve access, equity, and quality of well women exams. My name is Beth Kelsey. I'm the Editor-in-Chief for Women's Healthcare, a clinical journal for nurse practitioners, and I'll be serving as your moderator for today's event. Our presenter today is Kathy Sabag. Kathy is the Product and Market Validation Manager for Mobile ODT. She focuses on product management for new applications and strategic engagement with implementers, researchers, partners, and donors. Kathy has a background in global health and women's empowerment with a focus on program design to improve access, equity, and cost-effectiveness of community-based efforts. Prior to joining Mobile ODT, Kathy worked at the U.S. Agency for International Development, the Center for Global Development, and the UN World Food Program. Kathy holds a Bachelor of Arts degree from the George Washington University in International Affairs. We welcome Kathy today, and we thank her for her time and valuable information. This educational program is brought to you by Mobile ODT, creators of visual assessment tools aimed to bypass logistical and financial barriers to healthcare, to ensure every patient has access to preventative medicine and timely treatment. We thank them for their support. Now, I'd like to welcome our presenter, Kathy Sabag.
Thank you so much, Beth, for that really warm introduction. It's really such a pleasure to be presenting on this webinar today, especially because I know that nurse practitioners are really on the front lines of providing quality, effective, and patient-centered care in the U.S. today. And I know that each and every person on this webinar is making a big difference, especially for women, and we really, really appreciate your time away from the clinic. Today I'm here to discuss cervical cancer. And as many of you know, cervical cancer is a preventable disease that results from abnormal growth of cells on the cervix that really all sexually active women in the US are at risk for today. And today we're going to focus on providing screening for women at the community level for cervical cancer. And that's really an effective way to reach women with the highest risk and to catch growth at an early stage when it still can be easily treated. As everyone knows, nurse practitioners are really at the center of the conversation on how to reach high-risk women for cervical cancer, especially who really need this screening most. And today, first, I'm going to take you through the crisis of cervical cancer in the US today, different types of screening methods, and then I'm going to talk about how nurse practitioners can take real, simple 4 steps to providing screening or expanding services today if you're not already providing screening in your clinic. And today, 79 million Americans are living with something called the human papillomavirus. That's commonly referred to as HPV. And 14 million people are newly infected each year with the virus. Now, nearly every American will contract HPV at some point in their life. But this is important because HPV can lead to 6 different types of cancers. Cervical cancer is one of the most common types that can result from the virus, but certainly not the only one. And today, cervical cancer is caused by, in more than 90% of cases, by the HPV virus when it doesn't clear on its own. Because there's such a high HPV rate in the US today, we really need to make sure that all women at risk for developing cervical cancer are in a proper screening cycle to prevent morbidity and mortality. Now, the good news is that most HPV infections do clear on their own, but when the virus persists, it can lead to precancerous lesions on the cervix. And when it goes untreated for a long period of time, it can lead to invasive cervical cancer. Now, here on this slide, you can see the visual progression of a normal cervix all the way to invasive cancer. On the left, you'll see a normal, healthy cervix. And when the cervix is still normal, and most often among adolescent girls, this is a great time to vaccinate against HPV to prevent cervical cancer in the future. Unfortunately, not all women today have been vaccinated for HPV. And when a woman contracts the high-risk strain of the virus and it doesn't clear up on its own, HPV can lead to these precancerous lesions on the cervix that you see in that third picture. Most cervical cancer in the United States is found at this precancerous stage when women are in a normal screening cycle and it can be treated pretty easily. But if it's left untreated or left unfound, it can result in invasive cervical cancer, that picture on the right. Now, the good news is we can certainly prevent that pretty bad looking cervix by preventing invasive cervical cancer in the first place, by screening and, if needed, treating women at really early stages of cervical cancer. And how do we do that? We make sure that they follow different screening intervals and cycles. And the leading body to determine these types of cycles in the United States today is the American Society for Colposcopy and Cervical Pathology. That's a little bit of a mouthful. We normally call it ASCCP. And they recommend different intervals depending on age and medical history and risk, but really most often every 3 to 5 years. And there's different types of methods to screen for cervical cancer, and we break them out into three different parts. The first is primary screening methods, and this is really when a woman comes to the office for the first time and you want to make sure that she is not at risk for cervical cancer during a normal well woman exam or during her annual gynecology exam, depending on the type of patient you serve. The first method is Pap Smear. This is certainly the most well-known and most common in the United States. And the second is HPV testing. In both of these cases, you insert a speculum into the vagina, and you simply use a dedicated brush to scrape or brush around the cervix to collect a sample of cells. Basically, what we're trying to see is if a woman is HPV positive, we know that she's at risk for cervical cancer because more than 90% of cases in the US occur among women who are HPV positive. She definitely needs to be more closely screened to make sure that no lesions appear. Now, Pap smears are interesting. This is based on cytology. So the sample is put on a slide, put under a microscope in a lab, and the cells are reviewed to see if there's any type of abnormal changes. Now, if women are found to have an abnormal primary screening, meaning they're HPV positive, or the Pap smear came back with some sort of presence of dysplasia, whether it's low grade or high grade, or cells of unknown significance, they really should be called back to see what's going on. That's when we start to do a visual exam called colposcopy. Colposcopy is done with a medical device called a colposcope. And like the first exam, a speculum is inserted. And the little picture on the right shows a provider just visually looking at the canal, inside the vaginal canal at the cervix in a very magnified way to see what types of lesions may be there. Often a special diluted acid called acetic acid is applied to the cervix, and any suspicious lesions are usually white and pop out pretty clearly. Now, today I'm not going to go into the clinical side of colposcopy, but you are able to go to our website and see a webinar by Dr. Mary Rubin, who does explain some more of the clinical indications. If there are suspicious areas to be found in the United States today, most often women will undergo confirmatory biopsy to tell the type and the grade of lesion that's then used to make a treatment option. In most cases, women will not get to the secondary screening parts. They will normally have a negative Pap smear or perhaps a negative HPV test, especially if they've been vaccinated. And the second screening method is really only for women who had abnormal primary screenings. Now, what about treatment? What if you do have a patient that's found to have a precancerous lesion or perhaps cancer? In most cases, before the invasive cancer stage, treatment is pretty easy. Providers do things like cryotherapy and LEAP, depending on the type of cancer found and where it is and the stage. But in more advanced cases, lasers or even hysterectomy in rare cases may be used. The good news is that these are pretty easy screening methods to undertake in your office today, especially at the primary level. And that's why more than 69% of women in America today generally follow these screening recommendations. Yet still, even with these efforts in place and the relative ease to do screening, more than 13,000 cases of invasive cervical cancer are found in the US every year, and more than 4,000 women will die from the disease. That really means that both primary and secondary screening are not reaching all women in the recommended intervals. Unfortunately, the group of women found to have invasive cancer most and dying from the disease are most often women from ethnic minorities and disadvantaged groups. And when it comes to saving their lives from cervical cancer, not all women in America have equal access or certainly equal opportunity to appropriate health care. And I think this group knows that better than anyone. Today, only 22.8% of American women don't undergo screening within the recommended intervals, but more importantly, the groups that are the most high risk, those from ethnic minorities and lower socioeconomic groups, face the most barriers from access and awareness, cost, time away from work and family, and for many other complex reasons. 92.8% of the 9.8 million underserved women in the US today are not screened within the recommended intervals. And despite the Affordable Care Act making screening more affordable than ever, women are still not going under screening from the highest risk groups. And the rates of incidence and mortality follow the same narrative because women really aren't getting screening enough. And a 2017 study found that Black women in America today are dying from cervical cancer rates 77% higher than we previously thought. And they're dying of cervical cancer at a rate of 41% higher than white women. And they're also being diagnosed at a much later stage if they are found to have cancerous lesions. Hispanic women also have a very high incidence of cervical cancer, mostly in areas around the Texas-Mexico border, the lower Mississippi Valley, and southern Appalachia. And these women have rates 40% higher than those in non-Hispanic communities. Native American women also face significant risk and are nearly twice as likely to develop cancer as white women. And really, for these women, the remarkable success of the Pap Smear and different primary screening techniques in the United States that has reduced cervical cancer deaths by 75%, is still out of reach for these women. But at Mobile ODT, we really believe that there is an end in sight to these disparities. And from our personal experience building digital tools for healthcare providers in more than 26 countries around the world, we certainly believe it's possible to address the lack of culturally appropriate education about cervical health and the constraints and resources for healthcare outreach that really further entrench these seemingly intractable disparities in a cost-effective manner. So, in general, how do we reach these women? How do we make sure that we get to the community level and we get to high-risk women to make sure that they are part of that recommended screening cycle that is really quite easy to maintain once women have started? We really believe that that starts with nurse practitioners. And I don't have to preach to the choir. This group knows better than anyone that nurse practitioners really have a critical role in both primary and secondary screening of cervical cancer because of the more holistic perspective and advanced practice skills that enable this group really to intervene for clients at all levels of healthcare, from encouraging women to be screened in the first place, raising awareness and access among women who may not go to the gynecologist outside of a problem visit or outside of childbirth, to make sure that they're performing screening and successfully shepherding women through the treatment process. One of the biggest challenges is in high-risk communities, women may have been diagnosed, but they may not have gone through the proper treatment process. They may be really far from gynecologists, and they may not know how to make an appointment to make sure that they get the proper treatment, and they may not have the time away from work. What can nurse practitioners do to help this? First of all, nurse practitioners certainly have the tools to overcome the barriers. And we know that it's not just medical. It's not just having the Pap smears. It's not just having the equipment. It really means addressing the complex reasons why high-risk women, are not getting cervical cancer screenings. And these really include psychosocial, socioeconomic, and cultural factors. This really needs to be addressed at the community level. And that means nurse practitioners can encourage and advocate and lead the way, especially in high-risk communities, serving some of the minorities with these high incidence and mortality rates. And today, there is finally an improving recognition that nurse practitioners take charge not only of assessing the health of their female patients, that more medical side that we talked about, but also the system that serves patient needs, that really includes the education building, the counseling, and now also including that more clinical side to doing the primary and secondary treatment. And really, because women now more than ever because of the Affordable Care Act, have access to insurance that covers cervical cancer screening, it's critical that nurse practitioners integrate these clinical practices into their normal services and outreach, but also come from a holistic perspective to the woman, and make sure she includes this type of screening as part of her normal health care. And again, just underscoring the point that nurse practitioners have the best tools of any healthcare provider to understand the circumstances contributing to patient health beliefs and behaviors that get them into the screening cycle to begin with. And this is a quote from Carrie Zug and Wendy Groove that I really love. And it points out that nurse practitioners, try to foster a constructive therapeutic partnership with patients, and they emphasize empowerment, agency, and decision-making. And these are all principles that link to the clinical side. They certainly guide advanced practice nurses as they provide screening and diagnostic services. That is the colposcopy and cervical biopsy that I spoke about, as well as the treatment for precancerous lesions. And finally, I am certain, really certain, that this group is consistently cost efficient across diverse practice settings to help, and I think can really help lower the current $6.6 billion price tag that we have for cervical cancer screening each year in the US today. I think that if more nurse practitioners pick up screening efforts, we can really stretch that dollar amount to reach every woman everywhere and really rapidly lower some of these mortality rates of some groups in the United States that are similar to those, some parts even in sub-Saharan Africa. But that's all great. I think that the audience here will agree with me on these points. But the question I get asked most is, from nurse practitioners, is there a way for me to provide both primary and secondary screenings to my clients at a low cost? And the answer is absolutely yes. And it's probably much easier than you think to integrate cervical cancer screening into your practice and to start offering well woman exams. And the strategy is pretty simple. Today, I'm going to break it down into 4 simple steps. And on the following slides, I'm going to go through each step a little bit more in depth. The first step is to get trained in cervical cancer screening. The second step is to work with your local laboratory. You probably already have an existing relationship from blood tests and other types of preventative healthcare services you have to get the tools to do Pap Smears and HPV testing in your office today. And this is the really critical part for primary screening services in your clinic and your healthcare office. The third step is investing in low-cost tools to offer that secondary part of screening, that colposcopy and confirmatory biopsy, to make sure that women with abnormalities really come back for confirmation of disease. This is important. There may be cases where there are false positives, but we still want to make sure that all women are screened and we don't lose them in the process where they may have to be referred to other places. And step 4 is, as you expand services and you're newer to providing cervical cancer screening, or you have a really difficult case in your office, we need to make sure that nurse practitioners have the tools for real-time consultation and support from expert gynecologists or colposcopists using different new technologies out there so you can help your patients save extra time from going to specialists, time away from work, far travel, extra copays and expenses, etc., by bringing the expert opinion right to your device, right in your office. So now we're going to go into each step of the training, each step of the process I talked about. The first step is the training, and it's probably easier than you think. A lot of nurse practitioners in the past were a little bit nervous to get into colposcopy. It was intimidating. There was a lot of training, but things are changing and we're becoming more efficient. And today there's 2 options. The first is new courses led by the ASCCP that are really fantastic. They provide both training in colposcopy as well as treatment like LEAPS and cryotherapy to nurse practitioners who can then go back home and incorporate their skills into their practice, depending on your institutional policies. Everywhere is a little different. And it's only a 5-day course. And afterwards, it couples you with a mentor. And then you just do 25 to 30 supervised exams in your mentor's office. Now, more than 500 individuals have already completed this really excellent course, But interestingly, 90% of them are nurse practitioners. So it is already happening, and nurse practitioners are craving this kind of training. There's also a new online colposcopy training course. Mobile ODT is newly enabling this training course. It's a remote online didactic session, 4 different times over the course of a month. And then there is a one-day in-person hands-on training, and they're offered across the United States at different schedules. But what's really cool about it is that this course, you no longer have to have an in-person mentor if it's difficult for you. You'll be able to have remote mentorship through live video feed with other nurse practitioners and expert colposcopists to do these supervised exams. These courses are led by expert nurse practitioners who really power the course and take a holistic approach to training. And mobile ODT is just a technology provider to make it easy for you to do that live session and that live video portion for the mentorship. But again, the content and all parts of the clinical portion are led by experts in the colposcopy field today. One note on this, it's really important that you just check with your state regulations if some require additional documentation and mentorship components as you undergo the training. The second piece is to work or expand your relationship with a local laboratory. After training, you're going to need to start offering Pap Smears and HPV in your office. Again, it's pretty easy. You just insert the speculum, scrape or brush cells from the cervix, and send that kit off to the lab. And newer tests also have combined HPV and cytology. So you do one scrape, one kit, that's all. Your local lab likely has already in place an advanced system. So they'll drop off the specimen containers to your office, you label them, collect the samples, and then at the end of every day, that lab will pick up the results, will pick up the samples and have a pathologist review them. And the results will just be sent back via your electronic health record or fax, depending on how your lab works. Again, I think most of you already have relationships, so just give them a call to expand your offerings when you're ready. Now, what happens when you want to start doing that next step, that secondary screening? Many women still have the challenges to get the care they need if they have that abnormal result. And some of the challenges they face is lack of access to transportation to and from the clinical services, especially in rural America, where women have to drive many, many hours and may have poor access to knowledge how to make an appointment. They may also not have as good of access to treatment options. And so for this reason, following the training as well as providing the Pap Smears and HPV tests, you can consider taking up colposcopy in your clinic. Now, before I get into different tools to do colposcopy, no one should be nervous about doing this. There's been new research that indicates nurse practitioners can perform colposcopy and diagnostic procedures as competently as physician colleagues. I'm sure some of you are laughing, of course, but there are always some people in the room that are a little nervous. And a 2012 study conducted really to compare physician and nurse practitioner accuracy in recognizing cervical dysplasia during colposcopy found that these two groups of providers were similarly capable, and also studies in the United Kingdom and New Zealand reached similar conclusions. Today, I'm going to talk to you a little bit about the EVA system. Is one such tool that can help you expand colposcopy in your clinic. And this is before I get into how the EVA system works. I just want to read a quote from Dr. Mary Rubin, who has pioneered the colposcopy by nurse practitioners in the field today. And she told us that the EVA system really opens up a new world of user-friendly telemedicine for cervical health that can be utilized from anywhere to provide a broader spectrum of care and education to patients. So what is an EVA system? EVA system is a portable, connected colposcope that's low cost and can be moved between exam rooms as well as between clinics and for mobile-based efforts if you go to different places. It's pretty small, handheld, you can see on the screen, and it takes up a really, really little room in your clinic. And what it is, it's really a new generation of colposcope. It helps nurse practitioners ensure the results of the test, not only by visualizing the cervix in a much more affordable and a portable way than a traditional colposcope, but it has a set of online enabled quality assurance tools, including remote review by supervisors and peers. And the EVA system helps ensure that repeating the same test will give the same results by making the records from exams available securely online for immediate review, so consensus can be agreed upon by the healthcare team taking care of the patient. And it doesn't require all the members of that team to be present in the same clinic to get that consult. It's an FDA cleared device, and the software does meet all of the security and privacy regulations required by some of the largest hospital systems across the US. And the EVA system has been well received by both the patient and provider in a variety of settings. So, how does it work? This is an actual picture of the EVA system. It's a small handheld colposcope, and all you do is you input the patient information. You go ahead and you conduct that visualization. You take images for documentation. You can record the exam results right on the phone and enter the biopsy locations. And you can enjoy automated clinic note formatting that integrates directly in your EMR. It's very affordable and enables healthcare providers to focus on the majority of their resources on providing direct care instead of purchasing and maintaining some of that expensive equipment. And today I want to show you a short video on how one of our providers, one of our partners, Dr. Cheryl Gibson at Vermont Gynecology, is using the system today.
Having done colposcopy for now more than 30 years, I've had the opportunity to work with a lot of different colposcope systems. And the issues and challenges with them are that they are bulky, they're large instruments that are difficult to move around. I do think there's a strong need for more affordable equipment and supplies in women's health. I was first introduced to the EVA system device in early 2017, and the things that immediately attracted me to it were its portability and its great image quality. You turn on the button, you position the instrument between the patient's legs. You can see that the light quality is quite good. And you start to take images. It's that simple. One of the exciting aspects and features is the storage portal for the images, where you can go back and review your images, you can annotate your notes, and you can then interface with your electronic health record. As far as clinician education, because you're able to store the images in the portal, you can use them for teaching. You can actually pull up the images and enlarge the images on the screen and talk through with new trainees what it is you're looking at and why you would biopsy at certain sites. Patient education is particularly important when you're doing procedures on women. They really deserve to understand what it is you're doing and ideally see what it is you're doing. I can recall several times when I turned the EVA system around and showed the woman her cervix, just the surprise in her eyes, the delight that patients have when they're able to actually see what I was looking at and understand why I was doing biopsies or certain tests with them.
So as you saw on Dr. Gibson's video, the EVA system is really easy to use at the point of care, and one of the things we hear often is the concept of the cervix selfie. That's what we call it when you turn around the EVA system to show the patient what kind of procedure has been done and if there are any abnormalities present to help her understand and feel more empowered on the next steps of her treatment. And one of the things Cheryl Gibson showed you is how small it is in the clinic, but the EVA system can also go wherever you go. So from room to room, to clinic, or if you're working in some type of mobile outreach setup, it comes in a box and a portable stand, so you can really bring it anywhere. And one of the great things about the EVA system is that it's not just confined to the point of care like a standard colposcope. You can access all of your records anytime on an online portal. It's really a master portal for cervical health and anything related to cervical cancer screening that you've done in your office. You have all of your records there, all of the impressions you made, all the images very seamlessly, no cords, no transferring, none of this hard process. And that really allows you to search by a woman's name, the date of the exam, types of abnormalities. You can anonymize the images for different teaching purposes. And there's also a full quality assurance tool. So if you have trainees in your clinic who are working underneath you and you want to assess their diagnostic accuracy over time, you can open this special QA portal and say you agree with their decision or you disagree. And you can put in the type of treatment or diagnosis you would have made based on the colposcopy and the information inputted. And it will automatically calculate all of your trainees' rates of overdiagnosis or underdiagnosis, and as well as general agreements. So you can make sure that they're getting the right supportive supervision on the challenges that they face most. And what's really great about the cervical cancer portal, the mobility channeling portal, is that you, of course, can always pull up old records and look at a woman's images. So you can compare exams over time and really have that deep documentation tool that you need. And I want to share one quote from one of our nurse practitioners, Bonnie Betts. She said that Eva Colpo is one of the greatest things to happen to women's cervical health. It allows clinicians to review cervical images after an exam, and also really helpful for patients to be shown part of their anatomy they don't normally get an opportunity to visualize. And what's in one of the things she touches on is the ability for the Eva system to go beyond that traditional exam. And of course, because it is a digital tool, you can also go ahead and request real-time consultation and support via our secure collaborate feature to reach out to experts in your network to get a second opinion. And if you do have a high-risk woman or a very complicated case, to prevent women's having to travel really far, schedule an appointment with an expert, or really increase the cost of care from co-pays, etc. You can get that second and expert opinion to your office and really save your patient that extra cost and time. I know I've shared a lot of information both on cervical cancer and the US today and some of the new findings and research on the incidence and mortality being higher than we think, as well as the different steps you can take to provide or expand screening in your clinic. Again, it's those 4 simple steps: getting trained, getting the lab tests you need, that Pap Smear and HPV test, investing in simple digital tools. One example is the Eva system that we think is easy and portable. There's also many other different types of colposcopes out there you can use to provide that secondary screening. And the 4th is making sure you have those connections with experts to help you better serve patients in your office. We really want to reiterate, it's easier than you think. We'd be happy to support you along the way in any way we can. And together, we are sure that we can reach every woman everywhere in the US to get the care they really need and deserve through well women exams and gynecological exams.